Hi everyone, my name is Aman. I'm currently a foundation doctor working within City and Sandmore hospitals, and today I'm doing this short lecture about heart failure. I'll be addressing the following points. I'll start by talking about the concept of heart failure, some of the causes and ways that we can classify it, the clinical features, how to diagnose, and then how to manage it. I'll also be reminding you of some cardiac physiology to help support these points and explain this topic in more detail. So what do we mean by heart failure? Heart failure is defined as a state in which the cardiac output is inadequate for the body's requirements. It is not where the heart stops pumping. That is known as cardiac arrest and is something very, very different. Heart failure can happen acutely, which is uncommon and is considered a medical emergency. Today we'll be focusing on heart failure as a chronic condition because this is extremely common. And to put that into context, between 2018 and 2019, chronic heart failure in particular was responsible for over 80,000 admissions into the NHS. So you'll no doubt be tasked with identifying and managing this as a junior doctor. What are the causes of heart failure then? You could use the acronym IVF-CHARM to help you remember some of these, and they're listed here. Note that some of these are far more common causes of heart failure than others. For example, ischemic heart disease is by far the leading cause, and alongside hypertension and myocardial infarctions, they are much more common causes of heart failure than cardiomyopathy, which is quite specialist. By restriction, we're referring to any external forces acting on the heart which prevent it from relaxing as it usually should. This can include masses, or in particular, fluid in the pericardial space. There is a cardiomyopathy called restrictive cardiomyopathy, which causes a very stiff ventricle and can also lead to a restrictive cause of heart failure. So how is it that the causes mentioned on the previous slide lead to heart failure? In order to explain this further, I'll remind you of the Frank-Starling curve. On the y-axis, we have ventricular performance, otherwise referred to as the cardiac output, and on the x-axis, we have ventricular end-diastolic volume. This is the volume of blood in the ventricle after relaxation, otherwise known as myocardial stretch. The orange line denotes what the normal heart does on this graph. Increases in the end-diastolic volume mean greater myocardial stretch. This means the cardiac myocytes are more stretched because of more volume of blood in the heart, and that creates greater tension between the myosin heads and the coupled actin fibers. The greater tension means that there's a greater force of contractility, so more blood can be pushed out of the ventricle and we get an increase in the cardiac output. Increases in the EDV will therefore increase the cardiac output. Remember, however, there is an optimum level of stretch, and increases in the EDV beyond that point will cause too much stretch, where we can't really produce any more cardiac output, and this is how we get the plateau. The purple line shows what happens in heart failure. If we take ischemic heart disease as an example, this is where there's a buildup of atherosclerosis in the vessels supplying the myocardium. The atherosclerosis means there is hypoxia to the myocytes which can't function as normal, and also if it gets very severe we get small areas of ischemia, which means there is tissue fibrosis, and fibrotic tissue is very stiff and doesn't contract very well. As a result, for the same level of end-diastolic volume, a stiff ventricle will not produce the same cardiac output as a normal ventricle would. The same is true for fluid overload or in, for example, valvular dysfunction. If the aortic valve is regurgitating blood back into the ventricle, or we simply push too much fluid into someone, we'll get excessive stretch, and so the plateau is reached a lot earlier on. As a consequence, the heart fibers, the myocytes, are stretched too much, and once again can't contract as much to produce a greater cardiac output. There is of course a combination of things that happen in people that have heart failure. They'll no doubt have an element of ischemic heart disease, and also elements of fluid overload, and probably a stiff ventricle because of the ischemic heart disease. This is ultimately, however, the curve that is produced because of their ventricle undergoing these changes. And this is what happens in heart failure. That poor cardiac output is inadequate for the body's requirements, and so this is why we term it heart failure. Heart failure can be classified in different ways. You may have heard it being classified as left and right, systolic and diastolic, low output and high output. These aren't absolutely separate terms. For example, the left side of the heart can fail, and it can be due to systolic failure or diastolic failure, or a combination of both. And equally, systolic failure can occur due to low output or high output. These terms feed into each other, but we'll go through these one by one and address them, and hopefully it makes it clearer. It's just to remind you that you may see these terms being used in clinical practice, and they aren't absolutely separate. They do link together and sometimes are umbrella terms for other areas. When we talk about left and right heart failure, we are literally dividing the heart into its left and right chambers and their accompanying valves. The common causes of each are listed here. Because the left side produces a stronger contraction and relies on an effective blood supply to do this, it is more vulnerable to ischemia and hypertension. Remember that blood from the right side of the heart flows to the left, and so heart failure of the left side and changes here will also lead to changes on the right side eventually. So actually the most common cause of right-sided heart failure is failure of the left side. Cor pulmonale is right-sided heart failure secondary to COPD. Aortic and mitral valve diseases are also much more common than diseases of the pulmonary and tricuspid valve. The terms in the middle here are things responsible for failures of both sides. Often, when both sides of the heart fail, it will ultimately lead to tissue edema and pulmonary edema, and that congestion, particularly in the lungs, is what we call congestive cardiac failure. If you see heart failure being classified as systolic or diastolic, systolic is where there's a reduced ejection fraction. So in other words, the blood being pumped out of the ventricle is a small volume compared to the blood that was in the ventricle after filling. This is the equivalent of pump failure because the heart pumping action is impaired. As mentioned earlier, ischemic heart disease is the leading cause of this because of the fibrotic change that it causes, and the stiff ventricle can't act as an effective pump as before. Dilated cardiomyopathy can also do this because it overstretches the myocytes, which can't generate a stronger force of contraction, and arrhythmias, especially those causing bradycardia, because the time between ventricular contractions is so long that so much blood ends up filling the ventricle and we get overstretch of those fibers, so the force of contraction isn't as great as it could be and only a little bit of blood is expelled. Diastolic failure refers to the heart being unable to relax as best as it could. The ejection fraction is preserved, but there is a small volume of blood filling the ventricle in the first place, so only a small volume can be expelled, and as a consequence, cardiac output is still inadequate. Cardiomyopathies, hypertrophic and restrictive, can cause a stiff ventricle which doesn't relax as well, and the restrictive cause in the IVF charm acronym, because of pericardial effusion or tamponade, has the same effect. Equally, arrhythmias, especially those causing tachycardia, can have a similar effect. Because the heart is beating so quickly, there's not enough time in between contractions for the heart to fill properly, and so only a small amount of blood is able to be pumped out per contraction. A final way of classifying heart failure is through low output and high output. Low output literally means reduced cardiac output. Remember on the previous slide, I talked about systolic failure and diastolic failure leading to reduced cardiac output in different ways, which means low output heart failure can be an umbrella term for both systolic and diastolic failure. The terms feed into each other, so don't take these as completely separate entities, just remember that they're linked together in some way. Cardiac output is dependent on the heart rate and the stroke volume. And the stroke volume, if you remember from cardiac physiology, is dependent on the preload, which is known as the end diastolic volume, and afterload, which is the resistance to blood coming out of the ventricle. Increases in preload because of fluid overload or valve regurgitation, where there's a backlog of blood in the chamber, means that there's an increased stretch in the muscle fibers and not as much blood can be pumped out. Increased afterload because of hypertension or valve disease such as aortic stenosis creates greater resistance for blood coming out of the ventricle and also means that there's a reduced cardiac output. Changes in these or increases in either one of these means a decrease in the stroke volume, and a decrease in the stroke volume means there is a decrease in the cardiac output. High output heart failure is uncommon. It occurs where the body's demands are very high and initially met with a response to increase the cardiac output. However, when it's prolonged, the body in a way becomes exhausted and it leads to too much strain on the heart and it can no longer keep up with demand. And remember, if it can't keep up with demand, then that means that the heart is going into failure. It can occur in pregnancy, thyroid toxicosis, and even anemia, but it is very, very uncommon, and you're very unlikely to see this in clinical practice. The clinical features of heart failure are shown here, and you'll see that failure of the right ventricle will cause a different set of signs and symptoms to failure of the left ventricle. Some patients might have many of these signs, some might only have a few. Either way, you'll pick up on these through good history taking and good clinical examination. Most commonly, the ones that are easily identified would be pitting edema in the legs and the presence of fine bibasal crepitations, which will suggest congestive changes in the lungs. Some of these will only occur in severe cases, for example, ascites. When thinking about the severity of heart failure, you may have come across the New York Heart Association for the classification, and this looks at the functional limitations that heart failure has on the patient. Class 1 is very mild, and then Class 4 is very severe, and this ultimately determines the level of intervention that you want to perform and how much of an effect it's having on someone's life. The Framingham criteria is shown here, and it's a tool which can be used to help diagnose heart failure. You wouldn't be expected to know this by heart, but at least know that it exists as a way to help diagnose heart failure. In the community, we often measure the levels of NT-proB type natriuretic peptide, also known as BNP, because this is quite a sensitive marker of heart strain, and excessive heart strain will lead to excessive levels of BNP and so helps us understand if somebody has heart failure. In the hospital, if someone presents with a collection of these signs or symptoms, we often do an echocardiogram, and this will help us assess the heart function and ejection fraction, and therefore aids our diagnosis. The management of heart failure is most often medical, and we can use a combination of drugs to help us achieve this. Because cardiac output is inadequate, the kidneys often suffer the consequences of this, and when there's a reduced renal perfusion, there's overactivation of the renin-angiotensin-aldosterone system, where more salt is reabsorbed and more fluid is also reabsorbed. While this can increase cardiac output modestly, it puts people at risk of fluid overload because the heart just can't pump that extra bit of fluid out into the vasculature. We use ACE inhibitors and angiotensin receptor blockers to help us avoid this, and we can use diuretics to help get rid of that excess fluid. We also use beta blockers to help reduce the strain on the heart, which avoids ischemia. In some cases, we can use dilators and also digoxin, and often we obtain the help of the heart failure nurses who are excellent at optimizing the medical treatment and introducing and taking away medications. We can also use invasive measures to help manage heart failure. If there's a valvular problem contributing to the cause, then we can repair or replace the valve. In certain cases, if people have a poor ejection fraction and a broad QRS, we can use cardiac resynchronization devices which help coordinate ventricular contraction and maximize the ejection fraction. And in certain cases, we can always do a heart transplant. You will not see this as commonly because chronic cardiac disease tends to affect the elderly, and the elderly are too frail to undergo such invasive measures. So these things are typically reserved for the younger population. So that's the presentation on heart failure. Thank you for listening. To recap, we've addressed the concept of heart failure and looked at the causes and ways of classifying it. We've looked at the clinical features and how we can measure severity and the impact on functional status, the diagnosis, and then the management. These are some of the references I've used. Again, the Oxford Handbooks for Clinical Medicine and Cardiology are excellent resources.